In the last lecture, we had discussed about the assessment protocols for the trigeminal nerve, for the facial nerve, and for the half part of the vestibulocochlear nerve. Half part, it means in the last lecture, I already told you that for the vestibulocochlear assessment, we perform separate assessment for the vestibular part and again separate assessment for the cochlear part. So in the last lecture, we had already discussed about the proper assessment for the cochlear part, that is the assessment for any hearing loss. Okay, now for the second part is the vestibular part, the vestibular function. So here we will start with the vestibular function and then we will move on to the other nerves. Okay, first of all, before assessment of the vestibular function, vestibular apparatus, the vestibular system is one of the very important system, one of the very important apparatus of the internal ear. It is responsible for the detection of the movement of head and its position. Basically, the head's position is judged by the vestibular apparatus, and hence it is very important for the balancing of the body in a proper manner. So, if there will be any damage or there will be any lesion in the vestibular system or any or the vestibular part of the vestibulocochlear nerve, the chief symptom of the patient will be vertigo. This will be the major and the chief symptom of the patient. Okay, now for the assessment of the vestibular function of the vestibulocochlear nerve, we perform a test that is called Dix-Hallpike test, and if the Dix-Hallpike test is positive, then there must be any lesion or any damage to the vestibular system of the vestibulocochlear nerve. Okay, now for the assessment of this nerve, first of all, the patient's position should be sitting upright on the treatment table with both the legs extended. The patient should sit upright on the treatment table with the legs extended. After attaining this position, the patient's head is to be rotated to the one side by 45 degrees. We will rotate the patient's head to any of the side by 45 degrees and then we will assist the patient to lie down backward very quickly. The patient will lie down backward very quickly with the head which is held at 20 degrees extension. First of all, we have to rotate the head of the patient to the one side by 45 degrees. After rotating the head at 45 degrees, we will assist the patient to lie down backward with the head with 20 degree extension. It means the head is rotated at 45 degrees first and then it will be held in the 20 degrees extension. Okay, now after lying down the patient, we have to observe the eyes of the patient for about 45 seconds to 1 minute for onset of nystagmus. If the nystagmus is seen in the patient's eyes, then the test is positive and the patient must be having any lesion or any damage in the vestibular system. Now, after this vestibulocochlear nerve, the other nerve that is to be tested is the glossopharyngeal nerve. This glossopharyngeal nerve, it is the 9th cranial nerve. It is responsible for the taste sensation. The glossopharyngeal nerve supplies to the posterior 1/3 of the tongue and it also supplies to the palate. Apart from these two supply, it is also responsible for, it is also involved in the gag reflex. It is one of the very important reflex. If we are performing any reflex assessment on any patient, then this gag reflex is also tested there. For the glossopharyngeal nerve, it is responsible for the taste sensation. It is supplying to the posterior 1/3 of the tongue and the palate, and it is also responsible for the gag reflex. So, for the assessment of the glossopharyngeal nerve, it is best tested by checking for the gag reflex, if there is gag reflex present or it is absent. So, for the assessment of the gag reflex, we have to touch the uvula of the patient with any tongue blade or with a piece of cotton plug. We can use any of these two. So, whenever we touch the uvula of the patient with anything, there will be response. What will be the response? The response will be the contraction of back of the throat. Since this is a reflex activity, so there will be a sudden contraction of the back of the throat. This is the gag reflex. So, if there is gag reflex seen in the patient during the glossopharyngeal nerve, then you have to just chill because the glossopharyngeal nerve is very normal. But if the gag reflex is not present in the patient while the assessment of the glossopharyngeal nerve, then there is something to worry about, because if the gag reflex is absent, then there must be a lesion or damage with the glossopharyngeal nerve. After this glossopharyngeal nerve, we have the vagus nerve. It is one of the very important cranial nerve and it is the 10th cranial nerve. It is basically responsible for the motor supply to the pharynx. In the cranial nerve, we have some nerves are completely sensory in nature, some are completely motor in nature, and some are mixed. As we have already discussed in the previous lecture, that the trigeminal nerve is a mixed nerve because it has both sensory and the motor part. But here in the vagus nerve, it is mainly responsible for just the motor supply to the pharynx. So, the vagal lesions, if there is lesion in the vagus nerve, it can cause palatal and pharyngeal paralysis, laryngeal paralysis, and abnormalities of the esophageal motility. So these three conditions can be seen if there is lesion in the vagus nerve. Many patients lost their voice during the vagal lesions because of the pharyngeal and the laryngeal paralysis. Okay, so these three conditions can be seen in the vagus nerve lesion, in the vagal lesions. So for the assessment of the vagus nerve, first of all, we have to observe the patient while talking. The patient is explaining his or her condition, the patient is explaining his or her problems and issues with you. So you have to observe the patient while talking. If there is a hoarseness in the voice, if there is any whispering, or if there is any nasal speech in the voice of the patient with the complaint of aspiration or regurgitation through the nose, then these all are the features of the vagal lesions. Now, it is not necessary that all these features, that all these symptoms will be present in any particular patient. Some of these symptoms might be absent, but these all are the collective features and the collective symptoms for the vagal lesions. Now, these are just signs and symptoms. For the assessment, we have to ask the patient to open the mouth and just say as long as possible. Okay, the patient will open his or her mouth and say just as long as possible. It will cause pharynx to elevate and observe the position of uvula. Generally, in the normal condition, when the patient will open the mouth and say this word as long as possible, it will cause the pharynx to elevate. The pharynx will elevate and the uvula will be at the center. It will not deviate to any side. But in the vagal lesion, there will be no elevation of the pharynx or the palate, and the uvula's position will change. Uvula will shift either to the left or either to the right. It will not present in the center. As we have seen that in the normal condition, the uvula will be in the center and the pharynx will elevate. But in the vagal lesion, there will be no elevation of the pharynx or the palate, and the uvula's position will be completely changed. It will not be in the center. Okay. So after the vagus nerve, we have spinal accessory nerve. It is the 11th cranial nerve and it is also a motor nerve. It has not any sensory part. Okay, it gives the motor supply to two muscles. First is the sternocleidomastoid and second one is the trapezius muscle. These two muscles are basically responsible for the rotation of head to the opposite side of the contracting muscle, the tilting of head to the same side of the contracting muscle, flexion of neck by both sternocleidomastoid, elevation of shoulder. Elevation of shoulder is basically more seen with the trapezius muscle, drawing of the head back such that the occiput tilts towards acromion. So these five functions are some major functions for the sternocleidomastoid as well as the trapezius muscle. So to check this nerve, to check for the spinal accessory nerve, we have to test for these two muscles. We have to check for the muscle power of these two muscles. For example, if there is any damage with the radial nerve, we will what we will check? We will check the muscles that are being supplied by the radial nerve. We will check the power of the muscles that are being supplied by the radial nerve. Same here, since the spinal accessory nerve is supplying to the sternocleidomastoid and the trapezius muscle, so for the assessment of a spinal accessory muscle, we have to check for the power of these two muscles. After the spinal accessory nerve, we have the last nerve, that is the hypoglossal nerve. It is the 12th cranial nerve and it is responsible for the motor supply to the muscles of tongue. It supplies to the muscles of tongue. So don't confuse with this hypoglossal nerve and the glossopharyngeal nerve is sensory in nature, but the hypoglossal nerve is motor in nature. The glossopharyngeal nerve is responsible for the sensation of the taste to the posterior 1/3 of the tongue. But here in the hypoglossal nerve, it gives the motor supply to the muscles of the tongue. And hence, if there is lesion in the hypoglossal nerve, there will be paralysis and the atrophy of the tongue muscles. The tongue muscles will get paralyzed and the atrophy can be seen in the tongue muscles. Okay. Now, for the assessment of the hypoglossal nerve, again, since it is supplying to the tongue muscles, we have to assess for the tongue muscle. We will ask the patient to open the mouth and to protrude the whole tongue out. Okay. If the patient is normal, then the tip of the tongue will be in the center. It will not deviate to any side, either left or either right. It will be just in the center of the patient's mouth. But if there will be any lesion with the hypoglossal nerve, then the tongue will point towards the normal side. Why? Because the abnormal side is not working, the muscles of the abnormal side is not functioning. Hence, due to the muscle pull from the normal side, it will point towards the normal side. In the normal conditions, what happens? For example, this is the tongue of any patient. Okay, for example, this is the tongue of any patient. This is the left and this is the right side. So the muscles are here and the muscles are here. In the both side the muscles are present, and these muscles are counterbalancing their force. But if there is any paralysis in the left one, if there is any paralysis in the left one and the left muscles are not working, then what will happen? Then only the right muscle will act, and there will be no counterbalance between these two muscles. So right muscles will pull the tongue in this position, and ultimately the position of the tongue will be something like this. It will deviate to the right side. The tip will deviate to the right side because of the muscle pull from the right side. And here the left side's muscles is not functional, and hence they are not counterbalancing the force applied by the muscle pull applied by the right side muscles. So this is just example. It will point towards any side, which whatever side is normal, the tongue will point to that particular side. Okay, so this is how we assess for the hypoglossal nerve. And here we have finished our cranial nerve assessment. If you have any doubt regarding this topic, you can simply comment below in the comment box, and you can also DM me on the Instagram. So I will see you guys in the next lecture. Till then, be happy and keep learning.